Thank the Society for the privilege to come and present at this meeting, and I congratulate the organizers for such a wonderful meeting. So we're going to talk about the paradigm shift in the endovascular management of descending thoracic aortic dissections. A brief historical note, the modern treatment of aortic dissection is certainly attributed to Dr. DeBakey, who in 1955 reported a successful outcome, and classic in his way of presenting these is a year after repair. So he would develop a new operation, he'll make sure it worked, and then after that he'll come up with his presentation to the remainder of the medical community. So by definition, an aortic dissection is an intimal tear in the wall of the aorta. And dissections are certainly divided according to the way we treat them. Anything that involves the ascending dissection is classified as either the DeBakey 1 or 2 or a Stanford type A, and these require treatment of the ascending component first. Today we're going to focus exclusively on the DeBakey type 3 or Stanford type B dissections, which only involves a descending thoracic aorta. So when we talk about aortic dissections, we have to refer to the INSTEAD trial. And the INSTEAD trial, what they did is they randomized 140 patients to either undergo best medical therapy or TEVAR for the treatment of acute, uncomplicated dissections. And survival at 1 year was 97% plus or minus for both groups. So what was interesting is that those patients who underwent best medical therapy, about 15% of them, after the 1 or 2 year period, they underwent crossover to the TEVAR group, in which they required repair. And stent graft was associated with about a 92% occlusion of the false lumen, which is something that was not observed in other trials. So in general, from the INSTEAD trial, we learned that that TEVAR was certainly recommended for the treatment of, the TEVAR and the treatment of uncomplicated dissections did not improve survival compared to best medical therapy. And thus, for patients who present acutely with an uncomplicated dissection, we're going to define what complications are. Best medical therapy, which is control of the blood pressure with between 90 and 120 millimeters of mercury systolic, and close surveillance certainly allows for better outcomes or equivalent outcomes to TEVAR or surgical intervention. So what is the criteria for complicated dissections? Well, a dissection is complicated if it presents with rupture. There's malperfusion or end organ ischemia from the flap, either whether it's the renals, the viscerals, or the iliacs or femorals, aneurysmal dilatation or rapid expansion or dilatation of the aorta, uncontrolled hypertension in the face of best medical therapy, and also persistent pain, which may be attributed to the dissection. Sometimes persistent pain, if we can say that the pain is related to the dissection, gives us the fear that this may be ready to rupture at one point. So what do we do with acute complicated dissections? Now we're using these terms, acute and now dissections that have some complications. Well, either those patients who presented with rupture or malperfusion, we know that 88% of them will require some sort of revascularization to improve that malperfusion, whether a fem-fem bypass to improve the flow to the iliacs, or they will require, as an adjunct to TEVAR, they may require the branching of the visceral vessels and so forth. The outcomes at about 30 days was equivalent between the two groups, but we know that those patients who had malperfusion, their length of hospital stay was greater as a result of the additional procedures and the end organ ischemia they may have developed. Again, when we look at complicated acute type B dissections, we know that we need to intervene early, and we know that in those patients in whom we have to intervene with TEVAR, those who have a rupture, they do well. About 90+% of them, you exclude the rupture with the endograft, and patients do well. But those who have malperfusion, excluding the tear simply with the endograft is not enough to correct the malperfusion and get the flap to rejoin its previous wall, and about 42% of those patients will require additional procedures in order to achieve end organ perfusion. So TEVAR alone is not sufficient to manage patients who present with malperfusion as compared to those patients who present with aortic rupture. What happens to chronic and acute dissections who have complications? When we look at those patients, we know that the 30-day mortality for both may be the same, but the 5-year survival for those patients who present with acute dissections is much better than those with chronic dissections, especially if they undergo TEVAR. And we're going to go and talk a little bit about that. It seems somehow that acutely the TEVAR is able to expand that true lumen and push the flap against the media and the adventitia behind that's been left behind. In chronic dissections, the septum becomes very stiff, and it seems that it's much harder for TEVAR alone to improve perfusion. So we know that for acute complicated dissections, TEVAR does very well. For chronic dissections, TEVAR is not as good as in acute cases. When we look again at complicated and acute and chronic dissections, once again, mortality and paraplegia seem to be fairly similar in the early period, but at the end, sort of in the long run, in both groups, those patients who maintain an endoleak or perfusion of the false lumen will require intervention. And usually the intervention means that you need to extend the endograft all the way down to the celiac axis, and not just putting the short endograft to cover the above tear. And that's because when you have a long tear of the aorta, usually you have multiple re-entry or exit points where blood flow can reperfuse the false lumen. So in general, we know that for complicated chronic dissections, we need to extend the endograft and cover essentially the entire descending aorta. So the basic algorithm now is for the treatment of descending aortic dissections, we need to think about them not necessarily as acute and chronic, but as complicated and uncomplicated. Uncomplicated dissections, we treat them with best medical therapy, essentially pain control and blood pressure management, and we monitor them and look for those patients who are going to cross over to TEVAR, or those who become complicated. Once the dissection becomes complicated, these patients will require usually TEVAR plus or minus a surgical intervention. To be able to plan and really understand what we need to do in our management, we need to think about what's the new gold standard in imaging. We've often done CT angiograms with fancy 3D reconstructions to really take a look at the dissection and help us guide our management. But I think that's a little bit obsolete now. This is what conventional MRI gives you static images with a picture of the flap, but I think the new gold standard nowadays is dynamic MR, where you're really able to see the flap moving. You can really determine if a dissection is acute or a dissection is chronic. And as you see here, the chronic dissection, the flap doesn't move, it becomes stiff. And if you think about this, putting a stent graft in this may not necessarily be able to achieve expansion of that true lumen. Here's another example, a patient who has a dissection. This remains mobile, this element in the abdominal aorta, but you get some false lumen thrombosis, but there's still some mobility, so you know that this is an acute dissection that's starting to thrombose proximally. Here's some TEVAR examples. This is a patient who presented with a Stanford type A dissection involving the ascending and the descending, underwent ascending repair. The patient recovered from that operation, but as you see here, there's a large aneurysmal dilatation of the descending aorta. So what we did here in conjunction with the cardiovascular surgeons, the patient underwent debranching of the arch vessels with the donor being the ascending aorta, and then we proceeded to essentially stent graft the arch from the bypass to the arch vessels all the way down to the descending portion. And this is just the example of the endograft being deployed. And here we are preparing to extend our repair all the way to the celiac artery, and this is the completion of our repair. Here's another example. This patient had an isolated descending dissection. Eventually, you see the false lumen being large and going down the descending aorta. So we're preparing here to place our stents in the proximal part. You still see that there is an endoleak distally, and again, this patient required extension all the way down to the celiac artery. We know that IVUS can be of a significant benefit, especially when you're trying to navigate a tear that has multiple re-entry or exit points. And in this case, we have the IVUS that we're able to place in the false lumen, and with that, we're able to guide our wires and then our stent eventually over the wire into the true lumen and deploy our stent under IVUS guidance. So what happens to the aorta? We know that the aorta tends to remodel after TEVAR, and especially in dissections. And what we think a dissection does in the acute setting, it pushes the true lumen outwards, compresses the false lumen. Eventually, the false lumen will thrombose. The INSTEAD trial told us about 90% of the time the false lumen will thrombose. Others haven't really shown that high level of thrombosis. What we know for sure is that if there is a persistence of the true lumen, of the false lumen perfusion, whether with TEVAR or without TEVAR, that certainly increases mortality and also the risk of rupture, especially in the face of previous endograft repair. But we cannot finish talking about aortic dissection without talking about the intra-arterial septum and its motion. And as we said before, the implications of this is quite important. We know that in this instance, placing a stent graft may be able to collapse the false lumen and expand the true lumen. In this case, the true lumen may not necessarily be expanded. However, we still tend to use stent grafts in chronic dissection, especially if we want to minimize an operation by placing a stent graft all the way down into the aorta and then perform visceral or arch vessel debranching, which may be potentially a smaller operation than doing an extensive thoracoabdominal repair. But this certainly has implications in the future for actual device design and the choice of therapy. So what does the future hold? We know that with the advent of dynamic magnetic resonance angiography, we can now perform computational fluid dynamics, and we can look at the flows, at the velocities of flow. And we see here the true lumen, and here we see the false lumen. The true lumen is perfusing our viscerals first, and then the false lumen is also contributing to perfusion of the renal artery in this instance. And certainly we can pinpoint with quite some accuracy the multiple tears that may occur within the intimal flap. What would this help us? Well, potentially we may be able to predict, based on the velocities within the true and the false lumen, how dissections will behave and which areas are going to thrombose. So in general, we need to think about dissections as either complicated and uncomplicated, and not necessarily as acute and chronic. Uncomplicated dissections require medical management, and complicated dissections in the acute setting, certainly endovascular treatment, is the way to go. And certainly we need to guide our treatment based on symptoms and not necessarily on the presence of the dissection alone. Thank you very much.